Ladies and gentlemen, please turn your attention to the stage as we begin our session. Ladies and gentlemen, please welcome your panel on Diabetes and Obesity, an urgent global health crisis, moderated by Executive Director of the Institute's Center for Public Health, Edward Greissing.
Well, good morning, everybody, and welcome to the last day of the global conference. I trust everybody has had a full 3 or 4 days here and not too exhausted and alert, ready to go. And if not, I'm sure we'll have something interesting planned during part of this session. I won't share because honestly, I don't know what it's going to be, but I've just been told by one of the panelists to be ready. So all of you be ready because you may be next. So we're here today. We have a great panel with us. We have a leading patient expert in the disease of both diabetes, obesity. We have 2 leading physicians and a panelist that has and is leading towards a healthier generation for all of us that focuses on kids, families, and school systems. So as we move forward today, I think there are a few things that we know and we often talk about when we look at diabetes and obesity. And we look at, we talk about eating right, we talk about physical activity. We don't talk enough about the science of these diseases. And since there may be some of you that are scientific experts in here, I am not one of those, so we will try and keep the conversation moving, but give everybody a basic understanding of some of the complexities involved with the science of the disease, and also the mental health aspects of it when it approaches stigma. So you have isolation, loneliness, depression, anxiety, all of these deeply linked into what causes some of our chronic diseases. As you know, we probably spend, it's growing anyway, closer to 90% of our healthcare dollars that are going to treat chronic disease, and both diabetes and obesity are a growing percent of that number. So at some point we need to get a handle on this. We'll have a couple questions today that may give us some ideas of what those solutions might be. And I think, the conversation around the magnitude of this global burden, I think, will be important for everyone to sort of capture a different perspective when you leave the room. And the panel will be asked what a perfect world looks like, so you'll get to hear that from some experts. So if in typical Milken conference way, I will start with the slide. If I could have slide 4. I'll try and do these pretty quickly because I'm not a great fan of slides, but I do think that they help along the way. You can see from this slide here the sort of the scope of this epidemic, both in terms of the number of individuals impacted, as well as the cost of the disease. And where it's going is not south. So to keep that in perspective, I think will be critically important. I think if we could quickly go to slide 5, because you're not here to listen to me or watch the slides, at least the one, but looking by regions going around the globe, that gives you a sense of the distribution today, knowing that and you'll hear more about the Middle East and Africa today, that the numbers in that region are going to continue to grow. If you look at China, for example, I think back in 2016, WHO let out some data that suggested that by 2030, 70% of the population in China will be diabetic or pre-diabetic. So I'm not sure whether that's cultural, an introduction of our Western diet across the globe, but all of those are beginning to impact global health. If we could jump to the slide 6. So when we look at obesity and you look at the Mediterranean diet and you think how healthy it is, it's still a problem there. So if it's a problem in the Mediterranean, we know that it's beginning to be captured around the world. So as we move forward today and talk a little bit about solutions, if we could go to slide 7 too as well, you're going to see that the solutions might be simple, but as humans, we complicate them. So
we complicate.
So if we could get started, why don't we take off with Randy and get a patient perspective on this? Randy, you've had a wonderful life. I mean, incredibly interesting, and yet we're challenged by the disease. And I was wondering if you could just sort of share your experience and help us get started in this, because what we don't do is focus on the patient. We're focusing on everything else, and I think the patient voice in all of this becomes critically important. So.
Well, I was one from the lovely state of Louisiana, where I grew up. Just telling Debbie that. And, you know, food is king in the South, and sort of that sedentary lifestyle and sort of drinking and just a good life of eating and drinking and just having fun. And I was definitely, after college, overweight quite a bit, and I developed type 2 diabetes later on. So I was, I guess, the prime candidate, and we were just laughing because she's in Texas and I'm from Louisiana, and I was saying those states in the South, the Mississippis, the Alabamas, the Texas, Louisianas, are high at the level of the states that have probably the most diabetic cases, type 2 and type 1 probably. I think, you know, for me, it's funny seeing the slide talking about people that don't know that they have it undiagnosed, because I didn't know I had it. It's a very sort of sneaky, sort of interesting disease, which has led me to a lot of discoveries in my life. Going to the dentist, talking about gum health, dentist saying, have you gone to the doctor to check your blood sugar? Looks like your gums are bleeding. I don't know what's going on, but you should really go and get a checkup. You know, being the average male, not wanting to go to the doctor unless something's severely wrong, not doing that for a while. You know, feeling tired and lethargic, like I had a cold or a flu or something, couldn't quench my thirst. Wound up in the ER with a blood sugar over 500. And I go, I guess I should have listened to the dentist. I should probably really listen to people say you should see the doctor at least once or twice a year. And you know, I finally had an incurable disease that can cause all sorts of health problems if not really kept in check. And I had to really buckle down and change my life. So you talk about the psychology of it, because the behavioral modification of it, being that you have to change the way you look at something and think about it before you can change it, because you have to see where it's really wrong for you and accept that. Also, you know, from the weight loss perspective, I was sedentary at that time. I was over, I think I was 358 pounds. I mean, it's just, I was laughing at your slide about the donkey though. I couldn't have gotten on the donkey at that weight. This is, man, this just crushes me. But yeah, I really had to make some serious lifestyle changes. Diet and exercise really do work, but that diet, for me, is probably 70-75% of it. Because when you think about rural America, when you think about the impoverished towns, that McDonald's meal is like going out to Spago for them, because they can't afford to do Spago, so they can't afford to really have that quality. So that hot meal that they don't have to cook. So it's just, it's really tough. And I do believe that for China and the rest of the world, the Western diet, that's what's really changing the outcome of the diabetes there, because the food, I mean, there's sugar in almost everything you have. If anybody had toast this morning, sugar and toast, I mean, you can't, you know, and also some of the carbohydrates quickly turn into sugar. So it's really a tough road, but, you know, living with it, having been an obese person and living with type 2 diabetes has definitely changed my life for the better, but I was forced to make a change.
Yeah, so what were some of the challenges that you encountered along the way, and was stigma ever an issue?
Well, I was on TV at the time. We just started Idol, and it's a funny thing. I mean, I laugh at it now. I kind of laughed then too, because, you know, we would say on Idol, Kyle and I would always say, you have to have a thick skin to be on this show, because if you're going to dish the criticism out to people, you got to take it back. So people would walk into an audition and say, "Dog, you're fat." I go, "Yeah, I know I am. I got mirrors. What do you think? I don't see myself." You know what I mean? It was that, and I think really just the uncomfortability of being in your skin on TV, because TV does put 10, 15, maybe 20 pounds on you. And, you know, I wanted to look very cool and sexy and hot, but I was 358 pounds. But the funniest thing that happened to me once I started my weight loss journey, I remember seeing someone I hadn't seen in about a year, and they're like, man, you look great. I said, you said that to me last year when I was 358. Were you lying then? Are you lying now? Because it plays a trick on your mind, you know what I mean? Do you really see me? Do you really like me? Or are you just making comments just to be cordial and nice? But it was that, and I think just really trying to change my diet, because I grew up in the South with all the fried everything. That etouffee must have 1,000 calories per bite. And I mean, this food is like we would say in the South, never trust the skinny chef, because they're not tasting their own food, they're just looking at what it looks like. And, by the way, if all these condiments on the table, I'm not eating there, because you should taste it and it should come out as hot, as sweet, as salty as you know that I like. It should be ready for me to eat. So that sense of thing, I was talking to someone the other week that just went to Jazz Fest in New Orleans, and they were like, I forgot my diet because I wanted to just live that life. And that's what it's like. So, you know, lo and behold, years later, that life helped me to get to a very dark place in my physical and health care situation. So, you know. And listen, I say this to everyone that comes up to me and asks me questions. It's not one size fits all, because I got friends of mine that flourish on being vegan. I don't, I can't quite, but I call myself a flexitarian now, which means if I want a little fish or chicken or meat, I can have it every now and then. But, you know, I was looking at the Mediterranean diet, all the different diets, the keto thing, all the, you know, you just got to find what really is going to work for you that you can really stick to and adhere to, not for the time being, for the rest of your life.
Well, thank you, Randy. I'll get back to you on a question. I'll let you think a little bit about it now, and that's about people that have don't have the same access to both a support system and food and the opportunity, because of where they live, for physical activity to be less of a part of their life. But we'll go back. So, but Deborah, you're in a clinic, so I could ask you a couple of different things here that come to mind. You know, what's a day in your life look in a clinic? What do you encounter? What are you seeing? What are the trends? Where do you see things a couple years from now?
Yeah, I think to help you experience that, I might ask you to pretend like you were a patient in my clinic and what you might receive and what you might seek. So when you came in, you were given an envelope. It has a number on the front, either a 1 or a 2. I'd like you to open the envelope, and if you have a 1 on your envelope, I'd like you to take one of the red circles and put it on your hand. If you have a 2 on your envelope, I'd like you to take both of the red circles and put one on each hand, just like this.
Is it our military left?
You choose. So you either have 1 or you have 2, depending on the number on the front. And if we could have, I should look, slide.
This is fun.
Yeah, let's make it fun, right? Let's have slide 9. So I'd love for you to just walk on the path on a day. Maybe that's not 9. Maybe it's 10.
Slide 9.
Yes, slide 9. Thank you. Perfect. And then hit the clicker button again, because I didn't realize we weren't going to have the thing. Yes. So I want you to pretend like you have the disease of the big red O, right? And if you have 1 sticker, you are overweight. And if you have 2 stickers, you have obesity. Next slide, please. And along with the big red O disease comes many other diseases. And if you could advance that twice, please. And it's really just the tip of the iceberg, what you saw in that last caption, because it's actually 236 diseases that we now associate with obesity. And so if you have 1 red sticker or 2 red stickers, the likelihood is I can find a lot of other diseases for you associated with that. And Hugh's in the room, and he's found this number for us, which is, as of this year, the big red O disease is costing us $1.7 trillion in the US, which probably doesn't make us feel good, because we're costing our country a lot of money if we have this disease, right? Next slide, please. And there are things that happen to you if you have the big red O disease. In your work life, you're less likely to be hired, you're less likely to be promoted, you're less likely to get a salary increase, you're less likely, next slide please, to to find and receive medical care, right? You're less likely to do that. And Randy mentioned some really important things about this disease. And Ed asked me to talk a little bit about the science. So we talk about food and energy expenditure in the form of physical activity, but we know so much more than that now. So if you could advance that a little bit, I think 3 times, you'll see that we have genetics that play a role, things that I do to you as a doctor that play a role. Just advance that slide. The environment plays a role. And we have things that we love, like things that give us pleasure, that play a role in this, right? And all those things make our big red O disease worse. Next slide, please. But I want to tell you about 2 pieces of the science that we know now, because I really want everyone that has the big red O disease to realize it's not their fault, it's not completely under their control, it's their physiology. And one of the things that we know in science is that you have hormones inside of you if you have the big red O disease that work against you. As soon as my patient comes to clinic and starts doing well at beating their disease, the hormones that make them feel full go down. And we know this. And the hormones that make you feel hungry go up. And we know that. And it tries to drive us back to the place that we started when we have any success. I'm not going to get into the gut microbiome, maybe we will later, but I want to share one more piece of science with you this morning. So next slide, please. And that is the other thing, as soon as you start to do well beating this disease, your metabolism adjusts down. And we know this. Your metabolism goes down. So you're trying to beat this metabolism, you're trying to work underneath this metabolism, it just adjusts down, and now you got to work under it again. It's like we need to be an Olympic swimmer. We need a metabolic drag suit behind us to help that metabolism work a little harder. Next slide, please. And it doesn't have to be 100 pounds. I love beautiful, extraordinary weight loss, but a very small amount of weight loss makes a change. 30 pounds makes a change in many of those 236 diseases. Next slide, please. And this is a panel about diabetes and obesity. So my patients that come to clinic that have diabetes along with their obesity, we know that these 2 together work hand in hand to really advance their cardiovascular disease. And that small changes like what you see here really, really change risk. Next slide, please. So we also know from the science, from data collection, the patients struggling with obesity are less likely to seek care. And they're less likely to receive care even if they seek it. If you come to me, you will get the care because I work in a tertiary care center. This is my job. I do full-time obesity medicine. But if you seek out your care from your primary care provider, you may not receive it. They may not be prepared or trained to give that to you. Next slide, please. So I want to leave you with one challenge before I turn it back, and that is to think about the person first. Because this is a disease that comes with a lot of bias, a lot of discrimination, a lot of shame, a lot of personal feeling of fault when it's physiology. And we use the word obese all the time. And I want to challenge you to try to use the word obesity instead. Don't label the person, label the disease. And now I will just tell you that you can take off your big red O's, right? And you can throw them away as we leave today. But my patients that struggle every day can't. It's a chronic, serious, progressive disease. And that's what clinic is like. It's fighting against appropriate coverage of care. You may not know that their medicines are predominantly not covered in both the US and many countries globally. And if they're not, and sometimes they're just not even available, even if they are covered. And the same is true of surgery. So just ask you to think about some of that science that I shared, the hormones, the metabolism, the next time you see someone who you think in your mind is struggling with disease, and know that they're working against their physiology.
Thank you. I think there's one thing to reinforce that, and I think if you go back for those of us that are probably, we're more than in our teenage years in the mid-90s to where we are today, just that incremental weight gain over that time period has cost us $1.4 trillion. Imagine how you could reinvest that $1.4 trillion in different ways to improve the health of individuals and communities. So one question for you as a follow-up, if you are actively, I mean, you've got patients that struggle, how do you get patients committed to engage in improving their own health?
You know, it's very interesting. When patients find the right resources, they are engaged, right? They just have been told so many times there's nothing less than push away from the table and walk a little bit more. And that didn't work, and so then they're frustrated. When they realize there are resources, they get engaged. And I gave 2 people in the audience a special envelope that has something attached to it. If you have that envelope, could you stand up? Ed didn't even know he was teeing this up.
Nope.
You have my card attached to that envelope. Who are you? There's one. And there's one more. And there's the other. In terms of resources, what we have to understand in the United States and globally around obesity, but this number is for the United States, only those 2 people out of the 40% with obesity and the 33% with overweight get care. Only you get a medication to help you treat your obesity, and only you get surgery. 1% of the population struggling with the disease gets care. So you've got my card. You can get care, but what we need to figure out is how to get everyone else care.
So I'm going to ask one more question quickly on that as a follow-up, and then we'll move to Hawaa there. But what role then, when you're talking about patient engagement and support and knowing that they have the tools to do it, what role do, I'll say community health workers, social workers, nurse practitioners play in the ability to drive better outcomes?
This is where diabetes sets a perfect example, right? We use all those resources in the care of diabetes. We have diabetes educators, our advanced practitioners, our nutritionists, our dietitians, our providers. Everyone's engaged in that care. And in obesity, this serious chronic progressive disease that is just like all of those other diseases, we will never succeed against this disease and change that $1.7 trillion if we don't engage all of those people. There aren't enough of me. I need all our primary care providers doing it. There's not enough endocrinologists, and I'm not even an endocrinologist, right? We need every level treating those folks.
Yeah, I think what you look at is, we talk about the crisis, whether it's opioids, diabetes, obesity, but perhaps the biggest crisis we have globally is around infrastructure. And until we get our arms around that and start dealing it in a meaningful way, we're going to continue to struggle. We can make incremental improvements, I think, but let me switch over to Hawaa a second. And you bring a unique perspective, and as we talked about earlier, this is a global conference. So the global lens that you bring to this, I think, is critically important. You've shared some information in the past with the Institute, but if you could go through what you see in the Middle East, in the UAE, Africa,
Sure.
Sort of the trends, what's going on, what should we be concerned about globally because of the implications of that?
So as you said, this is a global conference, and I'm in a unique position. I'm an endocrinologist by training. I trained actually in the United States for 15 years. I trained at George Washington. So being able to train here and taking care of the patients, and then taking that to the United Arab Emirates, where I'm from, and practicing there as a clinician gives me a unique perspective. I also subsequently became deputy director of the center I work at, which is the primary center focused for almost exclusively for diabetics. It's the largest center of its kind in the country and probably in the Middle East. So being a manager and a clinician gives me a unique perspective. So I've been listening to all of the lovely comments, and it makes me smile because a lot of these comments apply to both. Because I have the unique position of having patients that trust me, we have these conversations all the time. For example, that this is a multidisciplinary approach. It's not just what you eat. It's not just your conversation with me. It's what you do afterwards. It's who calls you. It's who you discuss this with. I have to say, through all the years of my experience now in practicing in different countries, I think the multidisciplinary approach is the most important. But like you asked me a question about the trends, so let's start a little bit about the numbers. So if we could go to slide number 3, I believe, is my first slide for today. It's the slide after that. Number 3? Okay, before that? That one, yeah, very good. So this gives you kind of a general idea of the global situation, why it is indeed called a crisis. In North America, for example, it's going to increase by 35% from the year 2017 to 2045 to 62 million with diabetes. Similarly, all around the world, it's about the same. It's expected to increase exponentially. In the MENA area as well, it's going to go up by 110% to about 82 million. Now, I don't want to get bogged down on numbers because we could talk about numbers all day. Bottom line, it's going up. It's going to cost us a lot of money. There's different reasons for why it's going up, and we need to tackle it. The interesting thing about the UAE, next slide, please, after this. What I want to focus on here is how the United Emirates is unique and how I can add that information to the summit. Primarily the prevalence of diabetes. We mentioned numbers. Our prevalence is about 1 in 4 people. 1 in 4 people of an entire country are diagnosed with diabetes, and that's underreported. My opinion is that it's half. So imagine an entire country, half of its population are diabetic. We're not even talking about the pre-diabetics. A lot of these people are pre-diabetic, they're not diagnosed. And obesity is also common in the UAE. It's interesting that it's not as correlative as in the United States, meaning that lesser changes in weight in the UAE can lead you to have problems with your sugars. Now, there's probably a genetic basis to that. But just imagine a country, half of its population are diabetic. This is indeed a crisis. Not only in terms of, how do we educate the public? The Emirates has done a great job in educating its people. Everyone there knows what diabetes is. Everyone knows, what the main forms of treatment are. And I have to say, one of the things mentioned here today is the stigma around diabetes. I'm proud to say that my patients, I think, would agree with me that in the UAE, there's no stigma really to diabetes. It's that it's so common that everyone expects to have it. It's almost like a unifying diagnosis. Oh yeah, I have it, my sister has it. You don't have it? Probably didn't go check. So I have to say that one is not applicable to the UAE, I don't think. Also the access to healthcare. The UAE, thankfully due to the generosity of our leaders, provides free healthcare to its citizens. And it's one of the, what you could say, wealthier countries of the MENA area. You have to remember also that when you look at these stats, the MENA area is a huge area. Some of these countries have full access to healthcare, some of them do not. It's North Africa and the Middle East. In the UAE, for example, we have great access, we have great care. Coverage for weight-lowering medications exists. Coverage for gastric bypass exists. As long as you fulfill a certain criteria per guidelines, you are treated. But what are the results? There was a panel discussion earlier where they say, or the title was, you think that richer countries or those countries that can afford it have better health results. Untrue. It's not because we're not providing it. It's not because the patients can't access it. There's more to it. You can't just throw money at it. This is not a problem that will only get fixed with money. I'm not saying it doesn't help, but I'm saying it takes more than that. And the primary focus here is a team effort with your patients. You can't just, Mr. Randy mentioned something that I tell my patients all the time. I can't just order you to do something. I can't tell you, you know what, don't eat carbs, go home, go have a jog. That doesn't work. Right? We have to have a conversation. We have to have realistic changes. If a patient tells me, oh my God, I got diagnosed with diabetes, I'm gonna go and run 20 miles a day. I laugh. I say, that's great. If you're really scared, you might do it for a week or 2. And after that, how are you going to fit into your lifestyle? The Western lifestyle is creeping into the Middle East, not just the diet, but mainly the lifestyle. What do I mean? I mean, we work all the time. We try to find some time for our families. And when do we have time for ourselves? It's difficult. How do you get it into your daily routine to maintain it for the rest of your life? These are changes, small changes, that you have to maintain, hopefully for a very long time, to achieve your goal. And one of the things that you can do is incentivize the patients, but also think larger. How do we incentivize the workplaces? We have wonderful programs in the UAE now, where we actually have a competition between assets. We have a competition between different government entities, ministries, oil and gas, you name it, the police departments. And we say, okay, here are those step counters. Whoever gets the largest amount of steps gets this prize. And it becomes a communal environment. It becomes your job supports you, your coworker supports you, your family supports you, your healthcare supports you, your doctor supports you. And in the end, I really believe that this is how you get outcome.
So if you're looking at the differences between the US and UAE right now, there probably are more similarities than differences. But are there any cultural, you talked a little bit about lifestyle, but are there any cultural issues there that may be driving some of this?
There's similarities, like you say, in terms of sedentary lifestyle and the diabetes going up and obesity. There are similarities. I believe it's the same as in the US. The final graph on that slide shows a plot from data available online, the IDF Diabetes Atlas, where I plotted it and basically show a positive correlation between if you live in the city or if you live outside of the city, meaning that you're much more likely to develop obesity, diabetes, probably related to your activity level if you live in an urban area versus on the outskirts in the countryside. The differences, I think, is that I really don't think we're that big on fast food. People keep saying about how, the Western burger diet, goes in and changes things. I really don't think that's the primary concern, at least not for the many patients that I see. I think our existing diets, just at a larger amount, is the problem. You have to remember, the UAE is very young. It's about, 50 years old? We were not a country before that. We were something called the Trucial States. And in those days, I remember my grandparents always telling me, we didn't know when the next date would come from. We had no drinking water. If you had pure water, you were rich. If you lived in an oasis, you protected it. It was truly a harsh environment. You worked either as a fisherman from morning till nighttime, or you were hunting in the desert. Or you were a pearl diver. It was a simpler life, harder, harsher. All of a sudden, fast forward, modern life comes in, and now my patients, you know who I'm talking about, that are probably going to watch this at some point on YouTube, that will not come to their appointment. I kid you not. I give all of my patients my cell phone number. They give me a ring. Doc, I'm not coming today. Why? There's no parking. What are you talking about? I can see it out of my window. It's right over there next door. They're like, yeah, but it's not right in front of the center, so I'm just going to reschedule. You're 25.
Right.
Why are you? Oh, you guys should really get valet parking. You know what we did? We got valet parking for the center. Most of our hospitals have valet parking. Again, I'm not against it. I love valet parking myself. But it goes towards, for you to understand why this is a special population. This is a population that went from harsh life, the modern life. This is the textbook example, where you then develop the condition of modern life, which is now diabetes. Again, I also agree with not stigmatizing the patients. It's not just, excuse my language, that you're lazy, that you're sitting around doing nothing, eating whatever is in front of you. This is not what I mean. But I mean for us to ignore the fact or the reality that lifestyle has a huge role would be, disingenuous. It wouldn't be helping my patients. We need to face the fact that it does play a huge role. And then there's genetics. In the UAE, because it was a small population, we have a unique genetic background. I'm not saying that it's not amplified by that. Why is it that half of the population all of a sudden have diabetes? Why is it that the obesity rates are not as correlative in the UAE as in the Western world, like in the US? There's definitely a genetic basis. And I could talk about all the other conditions like MODY, if you want to talk about pathophysiology. When I was at George Washington, I only read about it. It was on my exam. I come to the UAE, MODY is very prevalent. Type 1 diabetes is also quite prevalent. So, and there are clear family trees that show that due to previous history of intermarriage between families, there's clear family trees of patterns of inheritance of diabetes. And I'd even go as far as saying that there's new patterns of inheritance in the Emirates that we can identify. We've identified them locally in our center, for example, but there's much more very good data that we could get from the UAE if we work together.
Thank you. But should I change my other slide from only in America to only in America?
Yes, you see, I was just saying I would never get away with that because, I'm not American, so I can't say that only in America. But yes, it's not only in America.
Okay, thanks. Kathy, you have a unique perspective of this because what we've seen when you look at the data that both type 1, type 2 diabetes and as well as obesity and childhood obesity overall, those numbers are climbing. And the work that you do through the school system at the Alliance is unique. If you could tell us a little bit about how the Alliance approaches this, how school systems are used, and what are you seeing? What's the uptake and success stories that you have?
Sure, thank you. It's a pleasure to be in this room with this esteemed panel here and also with all of you in the room. As someone who represents the not-for-profit on a national level, that's focused on children's health. And so I think I'll start with just a little bit of background about the Alliance for a Healthier Generation. We began about 15 years ago, a little less than that, but it was when President Clinton suffered his heart attack and then quadruple bypass surgery. That was all a surprise. Maybe in hindsight, not a surprise based on the lifestyle of unhealthy eating that he had been enjoying. But after that surgery, Nancy Brown, the CEO of the American Heart Association, approached President Clinton and started talking to him about what could we do from here and how to leverage not only their combined voice, but the fact that he had gone through this experience about suffering this severe heart attack and was looking at his own lifestyle choices around healthy eating and physical activity. And so what they decided is to not do a PSA. And they thought that they could do better than that, and they created this Alliance for a Healthier Generation. And then within a few years, it also became independent, not-for-profit organization. So we have a national focus. I'd like to say that we think globally, but act locally, the good old bumper sticker there. But that what we will do is work in schools and out-of-school programs, and what we bring is subject matter expertise, the evidence-based public health model that we adopted from the Centers for Disease Control. So using the science to develop our work and then to go into schools and help them create, not only do an assessment, but then to look at what things they want to change in their school environment, to set some goals around policy and environmental changes, and obviously engaging not only the administrators, the teachers, but also the parents and the community to say that these changes need to be made to support healthier children. And so our roots are based in physical activity and nutrition. And I was really proud. I've been with the organization now for 3 months and came from the other side of the world in health philanthropy. So I decided to switch chairs and go across the table. And I've learned a lot about, it's an interesting dynamic, you know, when you're relying on funding to make a difference. We're probably about a $20 million annual budget for our organization. And if I was to say that if we could be a $150 million budget, which is so interesting when you think about the numbers that we heard and that we spend on the disease. But if we were an organization that at $150 million, we could probably be at scale in this country with evidence-based work going on at the local level, with the technical assistance provided by our organization, as well as the guidance and coaching that is needed to support these schools to create changes, as well as out-of-school programs. And you think about, it'd be dramatic, it's dramatically hard to raise $15 to $20 million a year to do our work across the country. But imagine if we just had $150 million. I mean, how dramatic a change that we could create. And also being focused on not only the early years, but seeing the children all through high school. So, well, I think I'll pause there,
Okay.
and so that you have the setup of who we are and what we do. And I just would mention too that we've probably engaged with or touched about 49,000 schools across the country and 28 million children. And what we know is that when schools implement our model and work on that they're seeing the changes in a healthy weight in the school and in the children in the school environment.
So we take a look, I mean, the focus is around nutrition and physical activity. And I'm reminded of a TV commercial, since I do watch a little bit when I keep it on at night. There's this wonderful commercial that is both, it makes you laugh and depresses you at the same time. There's this kid playing with his games, and he calls his grandmother in the other room to bring him a grape soda because he won't leave the game to go get it. So he's not eating properly and he's not moving. So
He's distracted.
with that as a backdrop, and with technology developing faster than we can keep up with sometimes, and AI around the corner, what does physical activity look like for the kids that you're involved with right now, 2 years, 3 years from now?
Well, I think it makes, it's even more important that organization like the Healthier Generation exists, because we have got to support, our whole model is meeting, in our case, the people we want to serve, the children where they are, so out of school, after school, and in school programs. And technology is having a real impact on distracting children from even understanding the excitement of being outdoors, the pleasure of play, engagement in recess. And it's really creating almost like a one-dimensional world when they're away from their gaming, into trying to just think about how to be a child and how to be active and how to be outdoors and how to be part of engaging in nature. And it's interesting, when I went through the interview process, we even talked about what do we think our future is, because we work very closely with involuntary agreements with the food and beverage industry on how they are working to make changes to support better health for children. And I think the next opportunity for us is in probably working in technology and seeing how we can engage the leaders in technology to have just really thoughtful conversations, and if appropriately volunteer steps that they could be taking so that perhaps they're not marketing to the children in the way that they are, and creating a better balance there. I will share too, Ed, that something I'm very proud of, I think I started this earlier, that about the Healthier Generation organization is about 4 years ago they started, because our whole focus had been on nutrition and physical activity, but really sort of lifting up and looking at the whole school, whole community, whole child model, and recognizing that we needed to focus on social emotional learning and social emotional health. And with great support from the Kaiser folks, they have helped us build that muscle in our organization. We have a national content expert in Elizabeth Cook, who's leading our work in that area. And knowing that, that when we're in schools now, just to think about nutrition and physical activity changes is just not enough, and that we need to support, again, that whole school model and thinking about social emotional health built on the foundation of social emotional learning. So,
okay, how important is parental support?
It's incredibly important, and we most recently got a significant support by Kohl's to really start working on parent engagement. And so that's another piece or leg to the stool, if you want, that is critically important to us. And not only how we engage parents in this conversation, in solutions, in creating a family culture that can mirror a healthy school culture, but also support them by giving them tips, educating them, supporting them with ideas on how to deal with the different issues, the different pressures that children are experiencing, and so that they can have, that the child can have a holistic lifestyle to where they're getting these health messages throughout their day. And we hope throughout their evening, because we want them sleeping better as well. And we know that sleep is a big deal as it relates to children, and especially even to teens and adolescents, on getting more sleep to support their health.
More important for adults right now, but it's, I'm not
As
sure
well.
a lot of us got a lot of sleep this week. So we went a little longer on sort of the introductions to the experiences, but to give a good frame for some of these next questions. And Randy, I'll go back to you on this. If I left you with a question, and was wondering if you'd given that some thought and could
Will you tell me again what it was? Because listen,
You and I are both playing the same game.
yeah.
You
can't remember either?
Magic.
I love this game.
So it gave you the latitude to answer any question.
I think
you want.
everyone's overweight because of Netflix. That Netflix and chill thing is crazy. Talk about sedentary. No, I just, it's great hearing all the information, and I love A Healthy Generation is so amazing because I think it starts with kids and families for me. Because when I think about when I was a kid, what I learned and what I didn't learn, and I just kind of became what everyone did because you thought that that's what's the way you were supposed to live your life. I think it's also interesting what I just heard is that I wonder what country in the world is the healthiest?
Oh, actually had that.
Norway.
If it's by health outcomes and
By
dollars
obesity,
spent,
I mean, who's the,
Was it Belize? Benin actually.
I
had the
wonder what
lowest
that
rate.
diet is, and I wonder what that regimen is in the lifestyle.
I believe the socioeconomic situation there is a bit difficult. So in terms of the amount of sustenance, I think it's a bit of a difficulty there.
Right.
I do not know about their access to healthcare and things like that. But it kind of when I saw that, I actually noticed that country. It kind of hit me. I was like, oh, well, that kind of makes sense because I'm presuming that the amount of sustenance there is lesser. But I'm only making an assumption. It's not really healthy. It's
Right. I also love the idea of having advisors, and because as I say, I was a double major in college, psychology and music, but I'm telling you, after I could change the way that I thought about losing weight, because there's a lot of information out there, but there's not a lot. There's a lot of information on diabetes, but there's not really a lot, because if I got to go to a nutritionalist or an endocrinologist, somebody to tell me, eat this, eat that, because people are like, they need to really be regimented in what they do. That's why the vegan thing has become so popular. Just don't eat meat and don't eat this. That's why the whole keto thing, don't eat that. Because I think it's really hard for people to decide to give up these comfort things because nothing that we talked about, eating is emotional. Sadness, happiness, joy, whatever. I made a big deal. I got $100 million at the Milken conference. Who's giving that?
yay.
No,
Thank you, Ray.
no, but you know what I'm saying? It's a very emotional thing. So that's why it's hooked up to the psyche, even with kids, to their counselors in high school and junior high. Like, Johnny, how do you feel? Do you feel about your weight? Are people bullying you? Well, maybe I'll just eat something. I'll have some more donuts. We must really also get into the psyche of it. Because to me, that's where it starts. I had to change the way I looked at it, or else I was still going to be doing the same thing eventually.
If I may, just one comment to that. I would like to reaffirm what you just said. My patients and I, we have a way of communicating. I always tell them something called quality of life. They come to me, they say, okay, I'm going to cut out. We're very rice heavy. We love rice. There is no meal without rice and sweets because I think we never had it before. So I always tell them, very little of it, I should say. So what I always tell them is don't cut out anything. What are you talking about? You're going to get depressed. If you suddenly have a diagnosis of diabetes and you change everything about your life all at once, really? You're not going to maintain that. And you're going to get depressed. And guess what? You're going to open that fridge and you're going to eat everything in front of you. So you're absolutely right. There's a psychology behind it. We have comfort food, and it's okay. I work with people. I always tell them it depends on you. Some of this is everything is in moderation, might work for you. If you're super regimented and almost, excuse the wording, OCD, then fine, I'll pick a regimen that works for you. It really has to be tailored to the person.
Yeah.
Your quality of life has to be taken under consideration, and how you deal with it up here. My patients tell me it's an Arabic expression, but it means what you're saying. The smile is half of the treatment. What does that mean? That means that your psychology and how you're feeling determines half of the outcome. So absolutely, I agree.
So Deborah, you talked a little bit before about the body's response. So I would raise my hand here and say that I'm a victim of that Dow Jones effect, where you bounce up, you go down, and then your body shifts again, and then it's harder to get to that next level. What are some of the tools that could be used, and what role would the microbiome play in some of these, as one of those tools to respond.
So I think you bring up a really great point, and that is, I gave you all the same kind of red circle, right? And if you were to come to me and say, Dr. Horn, I have cancer, the first question I would ask you is, what kind of cancer do you have? Because I don't know how to treat you unless I know what kind of cancer you have. And with obesity and with diabetes, I think we haven't figured out, particularly in obesity, how to differentiate between the different obesities. And that's why people respond in different ways to different interventions. And some people succeed, and some people get frustrated, right? So every red circle looks a little different. And we have to figure out those ways that will help that person who needs that. Some people can manage their disease with beautiful psychological intervention, lifestyle, nutrition, physical activity, better sleep, lower stress. Some people need medication to interrupt those pathways. Right. Some people need surgery to interrupt those pathways, just like cardiovascular disease, right? As the disease progresses, as obesity progresses, you need more and more intense intervention. One of those potential areas beyond pharmacotherapy and surgery is the gut microbiome, and it's probably one of the top 3 studied areas in obesity right now. There's still so much we don't understand. So what I tell my patients is, if you see an infomercial at 2 in the morning that tells you, take this gut flora, not that gut flora, we don't know enough to say that, right? But we do have new interventions, including one that just came out in the last month, to try to interact with that gut flora, to try to intervene in kind of the negative milieu that might exist, and then some more invasive things around that. But we have a lot to learn about that gut microbiome and the signals that it's sending back to how each of us uses food differently. You know, we look at it and we go, I love that the restaurants now, at least in the US, are starting to publish calories, because it makes me think twice, right, on the menu. I look, well, I'm not gonna have that 870 calorie milkshake that I really wanted, right? But the other thing we have to remember is each one of us in the room utilizes that nutrition in a different way, right? And that's why 10 of us could all eat the same thing and do the same thing and sleep the same way and be on the same medication or not on the same medication and had 10 different responses. So I think part of it is really figuring out how to use the precision medicine that we're learning about, that the gut microbiome is part of, to develop individualized care for each patient that's suffering.
And how do we pay for it?
How do we pay for it? How do we pay? So I'm going to challenge you guys in the room. One of the things I think about is, if you're an employer, you've got to start to cover it. And everyone has to start to cover the disease. You know that most patients don't have coverage to come and see a provider, their primary care, or a specialist for the treatment of obesity. We have codes, but if I bill that code, I won't get reimbursed. So our employers need to start covering it, and it has to happen across the board, because the average American stays at a job 2.8 years, right? So why does Dell want to cover it if someone's going to leave there and go to IBM in 2.8 years, right? So we got to cover it across the board. And then we need help. We need help figuring out how to get the treatments in an affordable way to all the patients that need it.
Well, perhaps what we need to think of is how we can make insurance more portable moving forward, so that if insurance company X invests in a patient, that they don't lose that patient when they transfer to another plan. They still get some of the health benefit that they provided.
Exactly, and it's not unique to the US. In the UK, even though there's socialized medicine, the commissioners of each region in the UK decide what diseases get the most coverage. So in the US, patients change jobs. In the UK, they move to get better care for their disease.
I have a question.
Yeah, jump right in.
For the doctors, is there really an effective obesity drug?
Yes, is the answer. Okay, so
I
here's
mean, I
very
don't know
much
anymore,
so.
but I'm
Actually,
just curious.
this is what our primary caregivers don't understand, right? That we're trying so hard to educate them forward on, is that I showed you that you need to lose 5 to 10% to change a lot of those big diseases, hypertension, diabetes. If you can lose 30 pounds, 15 kilograms, we have a study out that shows we can put 50% of patients with diabetes into remission if they can lose 15 kilograms. Now they have to sustain that weight, and it's easy to do from a lifestyle intervention in the beginning and hard to keep it off, right?
Yeah.
And that's where our medicines and surgeries can come into play, helping patients keep it off so that they treat that underlying disease of obesity so that they don't have to be on 1, 2, 3, 4 diabetes medication.
Well, that's why I lost the weight initially, is to try and control my type 2 diabetes, which definitely worked. But I didn't know if there was, because I think people are so conditioned to take a pill. So is there an obesity pill?
So if I may just...
There's 7.
I'm hearing,
Wow.
I'm hearing several things here. I'm just going to summarize kind of. First of all, medication-wise, there's a lot of medications. There's injectables. There's a lot of medications. Purely, you know them. They're specifically approved by FDA just for weight loss. Forget being diabetic. We know and have known for a long time that, for example, gastric bypass surgery works right after the surgery, not just after you lose the weight.
Yes.
That goes back to a different
I
mechanism.
had it. I know it well.
So there's a lot, like going back to the tailoring to the individual, what works for you. But someone, I forget who asked the question, who's going to pay for it? A lot of these medications are not cheap. Okay, let's be serious about it for a second. There are no, as far as I know, please feel free to correct me, there's no longitudinal studies that I know about that will prove to me, or any insurance, or any government for that matter, that providing these expensive medications for, I don't know, XYZ amount of time will bring down costs in the long run. Okay, until you have, well, not with everyone, until you have at least some of these studies, it's very hard to push because the cost on healthcare is huge. The UAE, prime example, okay? I'm not shy to say that a lot of my patients were on injectable medication for weight loss. Okay, it was new, it came out, it works, it suppresses their appetite, they were very happy with it. But then all of a sudden, I even wrote an article on this, most of the country was on it. You've seen the stats, half of our population need it. So then that translates into costs. Now the government, the regulatory body asks the question appropriately. Yeah, now what? Like how long? Who are the patients? When you're talking about a place where 50% of the patient qualify per guidelines for these medications and all the other interventions, who's going to pay for it? Our leadership has been very generous and they continue to support it, but till when? We need sustainable healthcare, whether it's in the UAE, whether it's in India, whether it's in the US. There's something to say about tailoring treatment to the patient, but I believe that physicians also and the patients have a responsibility towards the cost. And it's a conversation a lot of people don't want to have. It's like, oh my God, it's medicine, we should take care of everyone. Yes, but you should also know what the cost is because then that's going to be a problem.
So let me try and pull this to a close because unfortunately when I do these things I have 1,000 more questions and we always have time. So it ties into what we're just talking about, but let's think of it's now 2025 and we've made great strides in the area of diabetes care and obesity treatments and care. What has happened? What does it look like? And what needs to be done? From a patient perspective, Randy, what would you say a perfect world looks like in 2025 for a patient?
Well, there's a cure for diabetes and a cure for obesity. Would love that. Wouldn't you guys love that?
Yes.
Yeah.
Deborah?
Here's what I need. 2025 is 6 years away. You have an opportunity this year to change something, and that is to get our legislators to pass a bill called TROA here in the US and set an example for the world. The Treat and Reduce Obesity Act will ask Medicare to cover Part D medications for obesity and to change where patients can receive care so they can receive care anywhere that they can find it for obesity. That will cause all of our commercial employers to then cover care because nobody wants to be as low as Medicare, right? Everyone wants to be better than that. And so we need to change that. And if we can change that, then what will happen in 2025 is patients with obesity will receive care. 90% of patients with type 2 diabetes struggle with overweight obesity. Those patients will get the right care to cover those diseases. And then the next step forward will be all the things that Kathy is working on for the next generation, right? That is changing the built environment, that is changing our quality of life, our work life, that we're setting a horrible example for the rest of the globe around, and making sure that people have low stress, high sleep, jobs they can manage, and have the ability to re-engineer physical activity back into their life. But if we could change one thing by 2025, I would say we have to pass TROA.
Thank you, Kathy.
Yeah, easy answer for me. So the biggest announcement out of the Milken Institute 2019 in answering this question would be the $1 billion investment in Healthier Generation to invest over the next 6 years so that every child enters kindergarten at a healthy weight in the United States.
Great, thank you. And from a global perspective?
From a global perspective, I think the one word that would probably cover it all is teamwork. Why? Because, as you heard, there are many different subjects discussed, whether it be legislation on the government level, whether it be insurance coverage, whether it be how you have the conversation with the patient, whether it be investing in healthy kid programs. You could tackle this from a million different directions, including making new medications. But we need, as a society, to realize it takes all of us, okay? It's gonna take legislation to incentivize it. It's gonna take companies to make peace with it. They're gonna have to focus on this because it improves productivity. Different governments have to do it their own way, that's fine. Patients need to be educated, schools need to be educated, Food and Drug Administration has to get involved. Incentivize taking sugar out of all the juices and the sodas. You need to tackle this from every direction, and it needs to become a societal responsibility to do so. This is no longer just about one person's health, one country's health. This is a global crisis, and they're not exaggerating titling it this. Because forget the money, don't forget the money, but it's trillions. But that translates, everyone thinks about the diagnosis of diabetes, like what it costs to treat it. What about the years lost? What about the productivity loss? What about the sick days? What about depression, psychological effect, amputations? It goes on. So we have a societal responsibility to all of us play a role in this. It's time.
Well, let me thank each of you for a wonderful contribution to the conversation. We came at it from a number of different perspectives, and I think that was very helpful because health is individual, it's local, and I think we've got a lot of different experiences exposed today and will help us forward. To all of you in the room, on a Wednesday morning at this late stage of the conference, I can't thank you enough for coming and making this a great session. So thank you, everybody. Enjoy the rest of your time here.